are temporomandibular disorders. And this is very important because the reason number one, the patient come into our office is because they have pain. The problem is that we are dentists, and the two main causes of pain in the head, in the face, are one, teeth pain, and the second one is temporomandibular disorders. And because we are dentists, which is the most commonly used treatment for temporomandibular disorders? This is very simple. We have a problem here in the temporomandibular joint. We are dentists. We do something very quick in order to solve the problem. We take the middle lane and then we put something between the teeth in order to solve the joint problem. So we use oral appliances. So what we do the dentist when we think that way is thinking with our hands and not thinking with our brain, because we quickly do something in the teeth or in between the teeth in order to provide a relief in the joint, because we quickly link joint problem with something in the occlusion. And this is the reason they are called occlusal splint. But then, if you are honest, and maybe it's from time to time, we have more time than expected in order to think about that. We need that we are enchained to those old concepts. And we still try to use them in order to solve a different condition that from time to time they have anything to do one from the other. It's like the six-blind man and the elephant parable. So 6 blind men touching different part of the elephant think that the problem comes from a completely different place. So the one who is touching the earth, so oh, it's a fan. The one who is touching the side, it's a wall. The one touching the leg, oh, this is a tree. The one touching the nose, or is this a snake? Or the one touching the tail, thinks this is a rope. And all of them are right, and all of them are wrong. And this is what we as dentists have been always doing. We have been learning too much inclined by people who didn't even provide a logical justification for their philosophies, mainly or many of them based on occlusions. This is like saying our sight only see what our mind is ready to understand. So we need to think seriously about that, because we only see what we want to see. But a man, what he thinks about all day long. So if you are always thinking that temporomandibular disorders has something to do with occlusion, you never will abandon that old paradigm. So, and this is, and I want to include this like a comparison, is when we began to use occlusal splints, which are not occlusal and are not splints. Maybe they are oral appliances or oral orthosis, but they are not occlusal because the mechanism is not occlusal, and they are not splint because they don't splint anything. We had wrong thoughts about how they work, and we took bad decisions. And this is the story about we begin to use oral appliances for the treatment of temporomandibular disorders. And believe me, when I give a course on TMD, the dentists are mainly at least 70 to 80% of them only interested in oral appliances, knowing diagnosis, knowing differential diagnosis, knowing clinical entities, not in diagnostic criteria, not in pain mechanisms, but only and oral appliances or occlusal splints. And we need to be aware that occlusal stents are really a part of a treatment approach and not always necessary. But dentists had a lot of issues, and they want to hear in temporomandibular disorder courses about oral appliances. I think Daniele is going to change the way you think about that. And of course, I'm not here to answer these questions, but to open your mind to think completely different. It's like saying that a mind is like a parachute. It doesn't work. It is not open. It's like saying also, something tell me that you are doing the wrong dance running beer. Why? Because you are doing something, it's not working. It was we must do. And if you don't get good result, it's not because you are doing the wrong thing, it's because you are not doing it right. So do you know why the Indian rain dance always work it? Because they dancing and dancing and dancing until it raining. And this is why many times we do with our treatments to solve temporomandibular disorder problems. But I love this paper, and this is not a paper in a dental journal, but an osteopathic journal that says that due to the natural history of disease, regression to the mean, and the placebo effect, the real signs and symptoms often improve with or without treatment. And that happens very often with temporomandibular disorders. And patients and practitioners often convince themselves that treatment was effective when it was not, due to confirmation bias and other human cognitive imperfections. And finally, the personal evaluation of efficacy is quick and convincing. So if I do something, anything, and it works because the patient is telling, oh, I'm better. And those evaluation of efficacy are not properly controlled, not scientific determined, or the scientific determination can be slow, complex, and costly. So it's very easy to say that it works because I do something, and the patient say, "Oh, I'm better." And those mechanisms of action of intraoral appliances, I love this paper by Glenn Clark many years ago. It's like the history of temporomandibular disorders, because they try to make the mechanism of action fit into the etiological theory that was supposed to be the right at the moment. So at the beginning, the occlusion was everything as an etiological factor for temporomandibular disorder. So splints worked because they did something on occlusion. You provided the better occlusal scheme, and this is the reason they worked. Then the vertical dimension. So all the temporomandibular disorder was due to a lack of or loss of vertical dimension. So because when using an appliance, you were recovering the vertical dimension, this is the way they worked. They came, Dr. Farr, and it said that there is some kind of misalignment of the maxilla and the mandible and the disc, and then we are providing those appliances in order to put it again to work properly, and this is the reason. And other authors use different theories, but all those appliances we have been using for more than 50 years, like Michigan appliances, it's called Michigan because it was first described by Sigurd Ramshaw and Majoras by the University of Michigan. Stabilization type of appliances were trying to follow some very strict morphological designs in order to provide a solution for an orthopedic problem. So they had to be in center relation because center relation it was supposed to be the best position for the temporomandibular joint. They had to be also constructed in centric occlusion, maximally intercruciate position because it's the most stable of the joint. They had to provide some kind of canine guidance in the lateral movements and or anterior guidance in the protrusive movement in order to provide lack of contact or interference in the posterior teeth. And this is the way they try to design or tell.
Also show them using a splint here, showing muscles and hyperfunction.
And then we were using those devices in order to produce better changes in the temporomandibular joint. And then even the design of the appliance was linked to that. So they were very fixed or very strict designs in order to provide a solution in the problem. And we think that this is the best way we can solve a problem where we use appliances. We think that those are the better schemes we can use. But the real truth is that any of those concepts has been completely demonstrated. Of course, we do the adjustments in order to try to get or to achieve those strict occlusal schemes. And we even think more orthopedically for different kind of problems of the temporomandibular joint. And then they can do anterior repositioning appliances in order to, according to FAR, there is a misalignment of the condyle disc relationship, and we are going to do this kind of appliance completely different because the etiological model was different and the therapeutic effect was different. And we wanted to test compared to the retrodiscal tissue in order to eliminate pain or to promote this formation. Nowadays, it has not been demonstrated even by the study by Robert Scapino that we can induce retrodiscal tissue fibrosis, but we wanted to align or realign the different parts of the joints in order to function better, in order to induce changes in the joint. And we use a different kind of devices, appliances, splints, what we want to call them. And all of them were with different philosophies in order to achieve different things. Myself, I have been using even axiographic tracings in order to program an articulator, to do an anterior repositioning appliances, doing an API in order to see which was the difference between the center relation and the maximal intercurval position, mounting spatial articulators. At the end, the answer was nothing worse because of those results. But we need to be critical also to that, because we always need to be good consumers of the scientific literature. The selections of the samples were bad, the diagnoses were bad because we don't even differentiation muscle from articular programs. We're always using the same procedure, the same statistical methods or the wrong statistical method. We didn't use objective method to be sure what it was producing some kind of retrodiscal tissue formation or not. So what we have been doing in the past in order to get information was set. And from there, what is interesting is that even in those cases which thermal derangement of the temporomandibular joint were misalignments of the condyle disc process, there were different philosophies of treatment. So, of course, when there is a anterior dysplasia, it can be an inflammation of the retrodiscal tissue, which can produce pain. But the real truth is that we say that, but we have seen many patients with displaced disc and no pain in retrodiscal tissues. And then using a repositioning appliance in order to realign the complex, the condyle disc complex, which was supposed to be the philosophy that recapturers use in order to get a better or proper position of the condyle disc relationship, is not nowadays accepted as the old truth, because there are many philosophers. We recapture this, put it back. Then they call the restore. So you put the condyle against the disc, and then you restore the full occlusion in order to reduce to fix the position of the mandible there. And then you do an occlusal rehabilitation in that therapeutic position, or you use overlays in order to move the mandible to that position that was supposed to be better for the joints. Or there were the reconstructors who do completely the opposite. The disc is here, the condyle is here. I'm a surgeon, I'm going to put the disc back to his place and always do like a surgical procedure. And there are, it was the origin of arthroscopic surgery. And there are other authors that believe more in physiology and the ability of the joint in order to produce a retrodiscal tissue formation that works as it was the disc. But the real truth is this one. We use those kind of devices. We try to modify temporarily the occlusion in order to get a better condyle this relationship. And secondary to that, we have a shortening of the lateral pterygoid, or we have an intrusion in the posterior, or we have something. But at the end, we have very important occlusal side effects, occlusal changes that many times lead to non-reversible occlusal changes with the use of these devices, with the, for example, the development of a posterior of the open bite. So, and I'm not saying that occlusion is not important. It's not an important discipline in dentistry, of course. It's it when we are doing orthodontics, when we are doing prosthodontics, we have to give the patient the better occlusal stability. But it doesn't mean that we always need to restore the occlusion in order to treat a temporomandibular disorder problem. So this is, for me, the key paper that which says, or is like a critical commentary or revision about if moving the mandible forward or putting the mandible forward forever after some kind of disorder is medically necessary. And the conclusion is those kind of permanent repositioning procedures don't fulfill any of the 6 criteria of medical necessity as appropriate and medical acceptable treatment or management options for patients with various of the different ND condition. This conclude also has very important ethical implications, and according to ethical standard, a physician is always expected to offer patient the best treatment option with the less risk possible, even if that appropriate approach results in less ideal financial returns for the dentist. So, of course, all the problems are not internal derangement. We have the myogyns, temporomandibular disorders, and this is part of my journey.